Hello, everyone, and welcome to the Hits and Misses of CF Newborn Screening, telling the full story from a health equity lens. My name is Karen Raraigh, and I'm a CF genetic counselor and assistant professor of genetic medicine at Johns Hopkins University. I will be moderating the session today, and we'll be introducing our other speakers in just a moment. Before I do, I want to provide a few housekeeping items. This session is being recorded and will be available after the event on the CF Foundation YouTube channel. You will be notified by email when the session recordings are available. We will be taking audience questions during the session, and we encourage you to submit your questions at any time into the chat box. We won't be able to answer questions about individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. We will do our best to answer as many questions as possible. I want to introduce Cambrey Vazconez White and Noah Singer, who will be sharing their family experiences with newborn screening later in our session. They are both parents of children with CF and will share separate stories about their children's health outcomes following newborn screening during the first 6 months. To set the stage, we will start our session by showing a new video resource for understanding health equity in CF, followed by an overview of the CF newborn screening process. Well, we're going to try to play in the health equity video. There we go.
It's critically important that we bring a health equity lens to everything that we do in cystic fibrosis. Back in 1938, Dr. Dorothy Anderson was the very first person to describe cystic fibrosis as a clinical entity. She actually described in the cases that she talked about a child who was Black and a child who was Hispanic. But unfortunately, those people were invisible to those who wrote the textbooks about cystic fibrosis. So it has been described repeatedly as a disease that occurs in white people. People who are Black, brown, they were left out of diagnosis, out of treatment and care for many, many years. So it's led to later diagnosis, which means people don't get care as early as they should. They are more likely to have severe infections and end up in the hospital a lot more. And they also are less likely to survive as long. These issues are built into the system. We have to be very intentional about knowing and acknowledging these differences because we know that there are preventable causes to poor outcomes that we're seeing.
I grew up in foster care from, I would say, the age of 3 until the time that I aged out at around 19 years old. I had all the symptoms and signs of having cystic fibrosis since I was an infant. All throughout my time in foster care, none of my medical needs were ever addressed. To tell you the truth, I never even had a physical before. So the only time I seen a doctor was in the emergency room when something critical happened. And each time that I would go, they would just tell me that I had chronic bronchitis or severe asthma, and they would just give me some antibiotics and an inhaler and just send me home. I was diagnosed at 24 years old. When he first told me, he looked at me and he said, it must be somebody up in heaven who really likes you because without any medication, without any treatment, you should have been dead by the time you turned 16. It's a miracle that you're here at 24. By the time I had my son at 32, I pretty much had a routine down as far as my CF was concerned. I remember when I gave birth and they put my son on my chest, he had this shallow breathing and I knew automatically something was wrong. So the next day, my son at the time that they were giving me the papers for discharge, he had threw up. And I remember saying to the nurse, could you give me the pediatrician? You know, my son just threw up and it's green. And so I remember her just taking a tissue and wiping it up and go, Mommy, it's not a problem. It's normal. Babies spit up all the time. And I said, but it was green. I remember seeing in her face how offended she was. So as I'm signing the paper, my son spits up again. This time I said, please go get the pediatrician. I need him to see this. So she goes to wipe it up again and I grabbed her arm and I said, no. Do not wipe it up. Get the pediatrician because I want him to see this. She goes, oh, Mommy, it's normal. Okay. So she goes and gets the pediatrician and he comes in. He sees the green sticky-like substance. And as soon as he sees it, he grabs my son out of my hands. He's running down the corridor with my baby in arms and come to find out that that green substance that my son was spitting up, that's a symptom of babies with CF. Had I went home and not advocated for my son, my baby wouldn't have made it.
Health equity occurs when everyone has fair and just opportunities to have optimal health outcomes. Health inequities lead to health disparities. There are health disparities in cystic fibrosis in diagnosis, care, clinical trials, and health outcomes. Health disparities are these poor outcomes that we're talking about that are preventable. For example, if someone is taught in medical school and throughout their career that a disease only occurs in people who are white, if a person who is Black or Hispanic presents to them with those symptoms, they don't have to be a racist to not diagnose that person correctly, because the system led to their inappropriate knowledge about what CF is and who it can occur in. We have to look at the systems that lead to these health inequities and thus the health disparities that we see in cystic fibrosis. The difference between equity and equality is making sure people have what they actually need. So if you think about, for example, a family going to watch a baseball game and there's a 6-foot fence there. If you give them equal ways of seeing over the fence, the man didn't actually need the box in the first place. The woman might actually now be able to see over the fence, but the child still can't. That's an equal solution to the problem. An equitable solution would be to give everybody what they actually need to see over the fence. What we really want to achieve is justice. So in healthcare, what we need to do is remove those systemic barriers, poverty, racism, remove those, and then everyone can achieve optimal health outcomes. Health inequity in CF has also impacted research in multiple ways. So for example, with the CFTR modulators like Trikafta, the mutations that were tested were based on mostly people who are white. And that's huge because people who were in the trials got to continue on the medication for years before it was approved. And therefore, people of color were disproportionately excluded from having early access to these medications. And even now, because mutations in people of color are more likely to be rare or understudied, they are less likely to qualify for these life-changing medications.
When I think of health inequity, I think of how even though I had all the signs, all the symptoms of having CF, I wasn't diagnosed mainly because I was African American and Latina. Had I been tested based on my symptoms alone, then I would have been diagnosed a lot earlier.
It's really important that we bring the health equity lens to every aspect that we take care of in CF. So when we're thinking about cure, when we're thinking about care, and when we're thinking about community, we want all of our treatments, all of our approaches to engaging people to consider the entire population of people with CF. We don't want it to be one person of color on a committee of 50 people, because that's not representative of what our greater population looks like. We need to bring those diverse perspectives to the table so that the person who is there is not thought of as the only voice on this one issue. We want every single person to be thinking about how can we make sure that outcomes in CF, that belonging in CF is something that every single person with CF feels.
I'm a part of a CF group that are people of color. And when you hear them say how sometimes they don't want to speak up for themselves because they don't want to come across as aggressive or as problematic. So sometimes they just won't say anything because they don't want that to affect the kind of services that they receive. That's unfortunate because if other members of the community are able to speak up for themselves and have other people speak up for them on the same issues, then they should be able to as well without any fear. And so I would hope that other patients and families can see themselves through my story and my experiences.
What gives me hope for the future is that we're actually having these conversations, actually working to identify the source of health inequity in CF means that we'll actually be able to start to make interventions that make optimal health outcomes a reality for every single person with CF.
I'm hopeful because I do see the changes happening. When I go to my CF center, I don't just see a sea of white people, from the doctor to the nurses. I see the attempt of involving people of color in the conversation and understanding the dynamics of people's backgrounds and people's way of living and how CF plays a part in that. I see that there's a desire to know and to make a difference.
We as the CF community need to acknowledge these health inequities and define the problem that led to these health disparities. We need to address these issues for all people with CF so everyone has a chance to have the best possible outcomes. It's critically important that we bring a health.
Okay, so I'm going to kick off the talking part of our session now. Here are my presenter disclosures. We just heard about where there are problems with health inequities and disparities in CF, and the focus of this particular session is going to be newborn screening. I seem to be having a lot of trouble advancing my slides. My apologies. There we go. So we heard in the video about how inequities lead to health disparities, which impact outcomes. The focus of today's session is going to be specifically on newborn screening for CF, as I just said, and we're going to talk about how the newborn screening workflow can lead to inequities and create disparities, but also how some of these problems could be addressed and how community members may be able to get involved as advocates. To start, I'm going to give a few basic facts about CF newborn screening. First, the point of newborn screening is to identify babies with conditions that are likely to cause significant health or developmental problems in childhood, and for which early treatment can make a big impact on outcomes. So CF is just actually one of many conditions included in the newborn screening test, and it's included in all 50 states. The newborn screening test, both for CF and other conditions, is pretty good, and it will detect most, but not all, infants who have a particular condition. Babies with CF who are not identified by newborn screening are said to have a false negative result and may have a delayed diagnosis. It's also important to note that newborn screening detects some infants who don't have CF, and that's why follow-up after newborn screening to confirm or rule out a CF diagnosis is necessary. Before we can talk about all the details of CF newborn screening, we need to get everyone on the same page with the general workflow. In all states, the initial step of the CF newborn screening test is called an IRT measurement. IRT is immunoreactive trypsinogen, and it's a pancreatic enzyme precursor that's present in the blood. We know that IRT is high or elevated in most infants with CF, so this is a good starting point for the CF newborn screening test because IRT can be measured easily from a small amount of blood collected from a heel prick. But it's also important to recognize that IRT can be high or elevated for many reasons, only one of which is CF. We know that CF carriers sometimes have high IRT, that premature babies or babies that had a lengthy or difficult birth may have high IRT, or that IRT may be somewhat higher due to just the temperature outside. So it's a good place to start, but it's somewhat nonspecific. So to get the test to be more specific to CF, if a baby is found to have a high IRT, the next step is a DNA test, where the state will look for genetic changes in the CFTR gene. If one or more CFTR mutations or variants are found, then that's usually considered a positive or abnormal or out of range result, which is reported to the baby's pediatrician and or the local CF center and or the family. And I am sorry for the tech issues. There we go. Nope. There we go. That's usually the end of the CF newborn screening process, and then additional follow-up by a CF center will occur to determine whether the baby has CF or not. This is usually when the sweat test is performed. And of course, an infant will not progress through this workflow if the results of any of these steps are normal or in range. I may have to call in IT help here, for which I really apologize. There we go. If a baby with an in-range IRT will not get DNA, so a baby with an in-range IRT will not get DNA testing, and the result will be reported as a normal or negative CF newborn screen. A baby with a high IRT, but who has no DNA variants, will often stop at that step, and the result will be reported out as normal or negative, with some exceptions that we'll discuss. The vast majority of the time, babies who don't progress through this workflow and who have normal or negative CF newborn screening results really don't have CF. but a small number do, despite their negative newborn screen results, and often have a delayed CF diagnosis. And this is the group that we would refer to as having a false negative newborn screening result. This whole process takes about 1 to 3 weeks, depending on the state and whether the results are normal or negative or out of range. Seems straightforward, yes? What surprises a lot of people is how much variability exists in this seemingly simple workflow. And that variability at any of these steps can impact which babies get picked up with an out-of-range newborn screening result in which state. So starting with IRT, here are some state-to-state differences. States get to decide their own cutoff for what is considered a high IRT versus one that is in the normal range. What's high in one state may not be high in another. Some states collect just one IRT measurement, but others collect two, and the DNA step only happens if both IRT measurements are high. At the DNA step, states decide how many different mutations or variants they want to look for. Most states use a panel, which means they predetermine which variants are going to be specifically looked for and called out if found. The panel will tell you whether those specific variants are there or not, but it won't give you any information about variants that aren't on the panel. One state looks for just one variant, F508del or Delta F508, while other states look for more than 600 different variants. And as you can imagine, the size of this DNA panel will impact how many infants are identified. A state that includes more variants will identify more babies who have at least one of those variants. I'll just quickly show you what this looks like in the US. You can see that it's kind of like a patchwork quilt of which states are using which variant panels that differ by number and the variants on them. So for example, states shown in black test for more than 100 different CFTR DNA variants with their newborn screening panels, but states with the light gray color use a panel that only includes 23 different variants. And then there are several states in between. Just to make things more complicated, some states do more than just a DNA panel with a predetermined number of variants. Some states perform DNA sequencing, where they read through every letter of the CFTR gene looking for changes, if one change was previously found on a DNA panel. This type of test has the ability to identify many more DNA variants than a limited panel, and states that use sequencing as part of their CF newborn screen will often only consider a result positive or abnormal or out of range if the sequencing test identifies both disease-causing changes. But even with this extra sequencing step, states may differ. Some will report all variants found in this step, even if we aren't able to determine whether they cause disease, while others will report just variants that they know for sure to cause CF. And here, just when you thought we were done with IRT, we aren't. Some states have another way to get to a positive or out of range result if the IRT is particularly high. In these states, even babies that have no DNA variants identified are considered to have an out of range CF newborn screening test if the initial IRT measurement was particularly high. This is sometimes referred to as a very high IRT or a fail-safe. And the goal is to identify babies that are at particularly high risk for CF based on their IRT results, even if the DNA test did not find any variants, since we know that panels are limited, but not every state does this. Lastly, we know that states may differ in their reporting practices, their timeliness in getting results out, and how they do follow-up and communication about these results. This can result in different families experiencing the newborn screening process differently, even if the results are similar. So we started with this relatively simple, straightforward process, but when you layer on all the places that the protocols may differ, you end up with this potentially really complicated flowchart. So why do we care so much? Well, obviously we're interested in figuring out the best practices for newborn screening that identify the greatest number of babies that actually have CF and minimizes accidentally picking up the babies that don't. But a really important consideration is who we're missing. So who are the infants that have CF, but who don't get flagged by the newborn screening process and who consequently might have a delayed diagnosis? Who are the infants whose families have had a bad experience with newborn screening? This is where we bring in the health equity lens. A major focus, we're gonna get there. I apologize. There we go. I'm going to try to keep that mouse exactly where it is. So this is where we bring in the health equity lens. A major focus of investigating current newborn screening practices has been on whether states' choices at the beginning of the newborn screening process disproportionately affect infants from different ancestral populations or racial groups. So here you can see the whole CF population born between 2007 and 2020. About 85% identify as non-Hispanic white, about 8.6% as Hispanic, and 3.6% as Black or African American. But here's the breakdown of babies in this time period who had a false negative newborn screening result for CF. This group had a normal newborn screen result that was reported as normal or negative, but then the babies were later diagnosed with cystic fibrosis. Even though non-Hispanic white individuals make up 85% of the CF population, they only account for 70% of the group that was missed by newborn screening. But when we look at Hispanic individuals, this group accounts for 15% of the babies missed by newborn screening, even though they only make up 8 to 9% of the CF population. Similarly, those who are Black or African American make up 6.5% of those missed by newborn screening, but only 3 to 4% of the CF population. Similar story with a delay in diagnosis. Almost a quarter of those with a delayed diagnosis are Hispanic, despite only 8 to 9% of the CF population. And about 6.5% with a delayed diagnosis are Black or African American, despite only making up 3.6% of the CF population. So these data tell us that of the babies who are missed by newborn screening, who have a false negative result and a potentially delayed diagnosis, they are disproportionately non-white ancestral groups. Here's a way to look at how a decision at the DNA testing step of the newborn screening workflow may create disparities in care. This is data from California and shows how many babies with CF are detected with a common panel that looks for 139 specific CFTR variants. Overall, it's pretty good and catches just over 95% of all the babies that are born with CF. This is the state of California specifically. But when we look at different ancestral groups, we can see that the detection rate for Asian babies is much lower at 72%, babies who are Black or African American about 83%, compared to non-Hispanic white babies at nearly 97%. Now we can look at how that same 139 variant panel performs in different states. So it works pretty well, catching over 95% of babies with CF in states that have a population that's less diverse, like Maine, Vermont, West Virginia, just to name a few. But in states with greater diversity, like California and Maryland, using this particular panel on the newborn screening test is going to miss a higher number of infants that actually do have cystic fibrosis. Understanding data like these has prompted some states to significantly expand their testing panels to 600 or more different variants. And this creates a more equitable test so that the differences between states like Maine and California may be much smaller than what we see here. As you've seen, there are lots of places in the newborn screening workflow that can affect outcomes and results. I've highlighted some of the differences that we see in newborn screening detection across ancestral groups as one example, but we know that other challenges arise as well as a result of the newborn screening process. Some of these challenges include timeliness in reporting results, communication difficulties due to language or understanding of the results, and ambiguity about a CF diagnosis when only one variant is detected by the newborn screening test. Here to share their stories following newborn screening are two parents of children with CF. They'll take you through their diagnostic journeys and highlight areas of the newborn screening workflow that didn't serve their families well. Then you'll hear from me again to wrap up before we open for questions and discussion. So with that, I will pass it over to Cambrey White.
Hi, everyone. My name is Cambrey Vazconez White, and my son, Roland, who is now almost 3, was diagnosed with cystic fibrosis at 6 months old after a false negative newborn screen. Newborn screening is an excellent screening tool that catches most babies with CF. Unfortunately, it does not catch all infants, and infants who are not white are disproportionately missed on the newborn screen. Unfortunately, my son was a part of the group of infants who were missed in part because of a CF mutation that I carry and passed on to Roland, H609R, that is only found in individuals with indigenous Andes ancestry, most of whom are of Ecuadorian descent, including myself. First, I'll take you through the process of how the state of California missed Roland's CF diagnosis, followed by how we ultimately were able to get a diagnosis at 6 months. As Karen mentioned earlier, newborn screening starts with checking the IRT level. In Roland's situation, his IRT was actually extremely high, and in some states would have been considered a positive newborn screen due to just how high his IRT was at 323.63. On the back of his newborn screen, it actually shows his high IRT number, although on the actual document, the print is rather small. Roland's pediatrician did have access to his newborn screen long before he received his diagnosis. So if you look on the screen, expected range in the state of California is less than 69. So his is way higher. Since IRT was so high, Roland's blood spot was moved to the next step, which was checking to see if he has any of the 77 CF mutations that are on California's panel. Next slide, please. So this is actually an example, or it is our newborn screening document and that we received. And I zoomed in on some of the confusing verbiage on the newborn screening. In the middle of the report, it is stated, no follow-up required, elevated IRT, and no mutations found using the California CFTR mutation panel. But below, it says no mutations identified using the California CFTR panel. However, this does not exclude the presence of rare mutations. If the baby has symptoms of CF or there's a family history of CF, please call the newborn screening coordinator for assistance. So there actually is a family history of cystic fibrosis on my husband's side of the family. And as I will share later, Roland was having weight gain issues, which is a symptom of CF. Unfortunately, I don't even remember having access to this document at the time. As a new mom, unless you get a call about a positive newborn screen, I'm not thinking about checking the fine print about anything. Further, we received this cover letter, which is on the right side of your screen, that said, the testing of your child is negative or normal, no further tests are necessary. I am assuming, although I don't actually remember, that I looked at the cover letter as a tired postpartum mom and thought, great, everything's normal. Looking back, I really wish the cover letter was not sent because if you look at the fine print, a very high IRT was not normal despite a negative newborn screen. So, since 0 CF variants were found, Roland's results were treated as a negative newborn screen in the state of California. So Roland was born 2 days after his due date at 8 pounds, 2 ounces. The first 2 months of his life felt normal, and at his 1-month wellness check, Roland was in the 40th percentile for weight. Around 2 months is when we noticed some issues. When breastfeeding, he would abruptly stop and start screaming in pain. We also noticed a downward trend in weight gain. At 2 months, Roland was in the 15th percentile for weight, and at 3 months, he was in the 3rd percentile. I was already worried when he went down to the 15th percentile, and I asked Roland's pediatrician to refer us to a pediatric gastroenterologist. From month 3 to month 6, we worked with the GI and added a variety of interventions to help him gain weight. We added a reflux medication to his regimen, and I was asked to stop breastfeeding and start pumping so we could add formula to my breast milk to increase the amount of calories he was eating. These interventions allowed Roland to maintain his weight at the 3rd percentile. My husband and I were still worried, so we asked for blood work, stool samples, and a sweat test, which we only knew about because his cousin has CF. Ultimately, the GI agreed to the request at 6 months, which showed sweat test results that are indicative of cystic fibrosis. To confirm the diagnosis, the blood spot that was run for his newborn screen was retested, but this time they did what is called genetic sequencing, which picks up almost all CF variants, and 2 CF variants were found that way, 2184 insertion A and H609R. This made his diagnosis official, and we as a family needed to process what this meant for Roland's future and honestly process the anger I had about a public health measure failing my son. I share our family's experience to advocate for more equitable and better timeliness in newborn screening. I think more equitable practices can be achieved by standardizing and expanding CF mutation panels in newborn screening in all 50 states to include more rare CF variants on mutation panels. Roland's CF mutations would have been caught in New York, which has one of the largest CF variant panels in the country. In addition, I think pediatricians and other healthcare professionals should consider a multitude of factors when assessing their patients. Our pediatrician knew Roland was struggling with weight gain in his family history of CF. If she knew that newborn screening disproportionately was missed in non-white infants, or she took a more detailed look at his newborn screen, she could have put all of these factors together and referred Roland to a sweat test at month 2, which would have reduced the time it took to get a diagnosis. I also acknowledge Roland's situation is rare, but still think better education about CF and newborn screening is needed for healthcare professionals. Today, Roland is almost 3, and despite having 1 hospitalization after the diagnosis, he is now thriving, especially because he got access to Trikafta shortly after his 2nd birthday. Now, Roland does have 2 rare mutations, and neither are actually on the FDA approved list for Trikafta, which is another story entirely. But thankfully, our insurance company approved Trikafta for off-label use, and it has helped him tremendously. So this was our experience with newborn screening for my son Roland in California. Now I want to pass things over to Noah, another parent whose son Levi also has a rare mutation that was not captured on Washington State's newborn screening panel.
Great. Thank you so much, Cambrey. Hello, everybody. My name is Noah Singer. I am dad to Levi and I'm going to share his experience. So if you want to go forward. Well, so Levi and his twin sister were born a little bit over 2 years ago. Spoiler alert, his twin sister does not have CF, but Levi obviously does, which is his story. So I'm going to go through all these milestones, and really the takeaway is the lack of an early diagnosis led to some pretty bad outcomes in the beginning of life. So day 1 of born, Levi just doesn't want to eat that much milk. We're talking about milliliters of milk. It's hard to fathom how small a milliliter is, but he's just not wanting to take it in. On day 2, they're starting to run some more panels, and Levi's blood sugar comes back low. And the nurses say, we're going to take him to the NICU, but, sometimes this happens. I wouldn't worry that much about it. He'll go there. He'll get some care. Day 3 is when things really kind of start to get bad. So some of his initial diagnostics, like in the previous day, the radiology doctor says, something didn't look right on Levi's x-ray. She wouldn't tell me anything specific. I don't know if she really didn't know or she was just kind of like didn't want to leave me along. And she wanted to do another x-ray with like a medical team in the room kind of leading that. And during this point in time, when they were trying to see if there's a fluid moving through Levi's GI system, they tried to get the fluid to move, but that pressure actually ripped his intestines. The pressure was because he had meconium ileus, so there's nowhere for the fluid to go, and so he had an emergency surgery. He gets out of the emergency surgery. He's repairing the NICU, and during that time, we get confirmation of the high RT1 CF mutation. But this is a time of a lot of ambiguity. And I remember this from talking to friends, and there's a 1 in 400 chance he had CF, based on this initial takeaway, because that's just kind of the odds that I was able to find online. And in Washington State, you'd see below, they test for 41 genetic variations. Levi has one relatively common mutation, N1303K, and then his other one is extremely rare nonsense mutation. While Levi's recovering, they see the surgical site where they had to put his intestines back together, starts to rip open. And so air starts to leak out. He needs another emergency surgery. We get that second CF genetic mutation confirmation on day 20. He's still recovering in the NICU. Then finally he gets discharged from the NICU. And if you want to go to the next slide, like this kind of gives like the mental model that's going through our heads during this time. At birth, there was no indication of CF, no family history, nothing pre-birth that would give any indication. The meconium ileus, we find that, and we learn that's a very likely outcome or symptom of CF. But then we see this one CF causing mutation and like, oh, actually, maybe it's 1 in 400. And then as you go along, we get more confirmation. And obviously the sweat test comes a little bit later and get ironclad. But this is just time, a lot of emotional volatility. If you want to go to the next slide. And so we get that CF confirmation test with the sweat test. One of the things that, and this is, we had to come up with some attribution of this, is when Levi's in the NICU, the team was not a CF center, right? He was at a hospital that focused on high-risk pregnancies because he was a twin, but they did not have a specialty in CF. And so he did not receive any chest treatments during that time. And with surgeries and his lungs repairing, his first years of life was in and out of the hospital. You could see all these milestones, chronic lung infections. And our belief is, just laying there, not moving around, these surgeries that cause this chronic lung infection to form and result in just a really hard start to life. Again, as you could see, day 50, day 130, day 150, it's a lot. And it just goes back to like, if we had any of those early signs where we could potentially have coordinated care a little bit better with the CF team, where we're able to get him the treatment he needed and potentially have a better start to life. I'll fast forward to today. So luckily, due to the papers that are written in the research, they found that people with N1303K and even a nonsense mutation can benefit from Trikafta. So like, as you see, literally just weeks after his second birthday, he was able to start Trikafta, and it's night and day. It's incredible. We went from, or I personally went from, hesitations on any long traveling that he kind of does well now. He gets a cold, it doesn't last for weeks. His nose doesn't run for a while. He just self-resolves. So the start of life was hard, really hard. We're doing much better now. He's doing much better now. The outlook is much more positive. But the big takeaway is, how do we help these kids in the future? Right. So with that said, I'm going to pass it back to Karen, who'll go over some things that you can do.
Thanks so much to both Noah and Cambrey for sharing their family stories. If you are interested in getting involved with efforts related to newborn screening, there are a few opportunities and ways to share your voice. Any individual who is 13 years or older, who has CF or is a family member of a person with CF, can join Community Voice to lend their experience, thoughts, and opinions to various projects. There is a committee that has been convened to formulate newborn screening guidelines. When the draft of those guidelines, which are organized by the CF Foundation, is ready, that will be sent out through Community Voice. And if you're interested in reviewing that draft, providing comments, please sign up for Community Voice. You can also sign up for advocacy alerts to receive opportunities for action in your state. So you can text NBS, that's for newborn screen, to the number shown to sign up. Additionally, you can request a peer mentor related to experiences with newborn screening and the diagnostic process. I promise we're almost there. We're gonna make it. There we go. We made it. The CF Foundation is working on improving newborn screening across the country in several ways. As I mentioned in the previous slide, a steering committee of experts is reviewing published scientific literature to develop evidence-based recommendations for best practices in newborn screening. The foundation also provides funding for awards that use quality improvement techniques to support changes in newborn screening, and there will be a request for applications opening up next month in May, which is tomorrow. Additionally, the CF Foundation is developing a strategy to leverage CFF advocacy to help improve state newborn screening programs. So with that, we're going to conclude the talking part of this session and open up the floor for Q&A, which I promise will have fewer tech issues because there are no slides to advance. So if you haven't already, please feel free to utilize the comments function to submit questions. And good, we're all back here. So I am going to kick us off as we wait for some comments and questions to come in. Some of you may have noticed that when you registered for this event, there was an option to submit questions then. So we do have just a few that were submitted prior to ResearchCon getting started, and we'll start with those. So I'm going to read them, and then the three of us are going to kind of rotate through and answer for things where we have expertise. So one of the pre-registration questions is, what is done when a family does not follow up on the results of their newborn screening? What is done with families when they struggle, are unable, or refuse to provide CF treatments and therapies? Now, we don't know where these questions came from. This sounds to me like it might have been a provider who asked this, though we don't know. The CF Foundation certainly can work with state newborn screening programs to use any methods possible to try to contact people. These are mostly going to be run through the state newborn screening programs to start. They can pull in the foundation, Compass, Community Voice, other advocacy programs within the foundation as needed. But there are circumstances, unfortunately, that if a state is unable to get a hold of a family following a positive newborn screen, when I say they use every method possible, they will sometimes send somebody to the house to try to get in touch with somebody. These newborn screening results are really important for CF and other conditions. And so if it's a matter of getting in touch with a family, the state has ways to do that. If it's a matter of engaging a family with CF care, the foundation certainly has resources to help work with clinics, to provide education, to provide resources and support for families who may be unable to handle treatments and appointments and things like that on their own. Cambrey, no, I didn't know if you wanted to add to that. No, okay. Next pre-registration question is that many patients describe worry and panic over receiving newborn screen results, even though this is not yet diagnostic, and many babies end up being carriers. How can we work with the state and primary care physicians to better communicate these results in a way that does not cause panic? So you learned through this process that follow-up sweat testing is really important, because the CF newborn screen does pick up babies that actually don't have CF, that are carriers, or that have a very high IRT for other reasons. And so really this comes down to education. And the foundation certainly does have outreach efforts to provide information to state newborn screening programs and pediatricians. I'll highlight one thing in specific, is that there is a committee put together through another genetics organization that is coming up with something called ACT sheets, ACT. These are designed to go to pediatricians that break down really simply, here's what the result is, and here are the steps you need to take next. Currently, there's only one for cystic fibrosis, but we are, so I'm on this committee. We are actually in the process of validating, I think, a total of 3 or 4 different sheets that will provide step-by-step instructions and break down the difference between a likely carrier result and this is maybe CF and what you need to do next. So we're hopeful that type of education will help. And our last pre-registration question before we get into the more live Q&A. Our daughter was missed by the CF screening in Texas with inconclusive results for her. The parents have El Salvadorian descent, and she has rare mutations. How can we get her mutations on the screening list to help others with her mutations begin their journey with a correct early diagnosis? And this is very similar to Cambrey's story that you heard about Roland, so I'm going to turn it over to her.
Yeah, so it's definitely a process, and to this day, I don't know if my son's mutations are on California's newborn screening, but there's ways to help the process. So I think some general things you can do is, on the previous slide, there is currently a working newborn screening steering committee, and eventually they're going to create recommendations to improve newborn screening to hopefully include expanded mutation panels. And so definitely read through that once it becomes available for public comment. However, one thing I did that I would encourage you to do as well is I was very angry and wanted to talk to everyone about how we could get some rare mutations on to California's screening panel. And so what I did was I called the number on the newborn screening paper that I got. And then eventually I found the right person to talk to at the state. So I ended up talking to someone at the state newborn screening lab, who's kind of in charge of everything, and just shared our story and asked, how can you get these mutations on the list? Clearly there's a need. And while they can't say, oh yeah, we're going to do it, because there's a lot of things that to take into consideration, including cost, unfortunately, but it's definitely a step forward. Now they know there really is a need. So yeah, I would encourage you to call your newborn screening, state newborn screening lab in Texas. And if you can find the newborn screening results, there likely is a number you can call on that paper.
I'm going to piggyback that with a question that was put into the comments, because the answer is very similar, but I want to just make sure that the person who asked it gets addressed. So the question is, when you say states decide, who or what organization in the state is in charge of determining the workflow? And as you just heard from Cambrey, there is a state newborn screening lab. Sometimes it'll be run through the state health department or the state public health department. So there might be slightly different names, but there is a laboratory or a group in each state that is in charge of newborn screening. So if you're able to get your hands on a result, find a phone number, and that would be the place that would sort of be the people who are in charge of that. All right. Next question from the comments. Is there any similar advocacy going on to increase the number of genes in the recommended maternal screening panels? In pregnancy, CF carrier testing is offered, but the panels available vary from as few as 32 mutations to as many as over 1,700 mutations. That is true. I'll answer this first, and then I'll kick it over to either Cambrey or Noah for further questions. So the short answer is that there are a couple of organizations that put out guidelines related to carrier screening, both for CF and other conditions that should be offered in pregnancy or prior to pregnancy. Those organizations are called ACMG, which is the American College of Medical Genetics and Genomics, and ACOG, which is the American College of Obstetricians and Gynecologists. Now, in 2003, they set a minimum screening panel for cystic fibrosis at 23 mutations. That was what everybody had to offer for carrier screening at the minimum. Now, labs could offer many, many more than that, up to 1,500 or 1,000, 1,000, 1,200, 1,500 if they wanted to, but they all had to offer at least 23. That number stayed at 23 for 19 years. And I'm happy to say that last year we released a set of guidelines that upped that number to 100. And the idea behind that was to increase the number of carriers in the general population that are actually going to be detected. So as it stands, the minimum recommendation now is 100 different mutations, and that will achieve about 95% coverage within the US population. So of all the CF carriers out there in the US, we expect that testing for 100 of these variants will pick up about 95% of them. Now, that's not 100%. And labs still have the ability to offer bigger tests than that 100, but that's somewhat lab dependent and somewhat provider dependent, and also somewhat insurance dependent on what would be covered. Cambrey and Noah, did either of you want to comment on that?
Yeah, I'll comment. I personally have not seen advocacy with this other than what Karen just shared, which is amazing. I don't think I mentioned this, but I also had a false negative carrier screening. And we were living in Hawaii at the time, and it was a 23 mutation panel that was missed. And our OB incorrectly had shared with us that if I was negative, we didn't have to worry about my husband, even though my husband has a history of CF. So I definitely think education at the OB level is important as well. But yeah, I definitely think that there needs to be similar advocacy on this level as well.
Yeah.
All right, I'm going to direct go ahead, Noah. I'm sorry.
No, I mean, James asked the question, like with the genetics, we wish the genetics community knew, like in our first conversation with Karen, like this is where my mind went. It's kind of connecting Laura's question too. It's like, what can we do upstream, right? When you're planning for a family, etc., right? Like, that's where my mind goes. So that would be the thing I would ask for, right? Prevention to a certain degree.
Cambrey, I didn't know if you wanted to weigh in on that as well. The question was for both Noah and Cambrey. What's something you wish the genetics community knew about your experiences?
Oh, that's a good question. I think what I wish the genetics community knew was just, I mean, honestly, I've had some really positive experiences with the genetics community, and they're actually the ones that kind of explained everything to me in a very easy and understandable way that I could receive it. So I actually don't really have anything other than kind of what I shared, which is more about education with the general healthcare professionals that are working with cystic fibrosis patients.
Noah, anything else to add to that? No. All right. It looks like, I'm just checking the comments here. It looks like we are done with the questions. So I'm just going to close us out here and say thank you so much to everyone for your participation, for the great questions, for the feedback. Before you go, please fill out the satisfaction poll, which is under the poll tab on the right-hand side of your screen. So I'll give you just a sec to go look for that. It's right next to the session chat. There are many wonderful resources related to this discussion, including the slides from today. I think somebody had asked a question about the video being available, so that's embedded in the slides. All of that can be available in the resource document that is found on the reception page. So please spend some time exploring the resources, download anything you want to keep, and please feel free to reach out to the foundation with further questions. We hope you are enjoying ResearchCon, and please go find your next great session to attend. Thanks so much.